We've just formed a quorum, and it's also the appointed time. May I call the meeting to order? Item number 1, information papers issued since the last meeting. Please take a look at the paper, and if there are no other issues, perhaps we can discuss the the agenda for our next meeting. Please invite the administration to join us. If I remember correctly, last time we had an item on specialist outpatient services deferred to the next meeting. Do members have other issues? Welcome. Dr. Ko. Right, the third item is proposed loan for development of the Chinese University of Hong Kong Medical Center. The administration would like to consult us first before going to the FC. All right, welcome administration. Any briefing from you, Secretary? Thank you. We've invited Professor Fogg and also Dr. Feng Hong from the Chinese University of Hong Kong to the meeting. So, we'd like to brief members on the proposal to provide a loan to the Chinese University of Hong Kong Medical Center. For some reasons, we don't have enough capacity in our private sector, and because of the healthcare reform and the proposed voluntary medical insurance scheme, we have to expand the capacity of private hospitals in Hong Kong. And the Chinese University of Hong Kong is proposing to develop a non-profit making private teaching hospital, or the Chinese University of Hong Kong Medical Center within its own school premises. It will provide 24-hour outpatient clinic and teaching services. It will operate on a self-financing basis. When on completion, it will be able to enhance our capacity in the private sector, offer more choice to the public. It will mainly serve Hong Kong residents, and it will provide packaged services to the community to ensure that people can have access to quality private medical hospital services, and training will be provided. At 2014 prices, the cost will be $6.3 billion, and we will take measures to facilitate the development of the hospital. We will allow a modification of the conditions of grant at a nominal premium of $1,000, and to provide a loan of $4.033 billion. And the CU is willing to accept patients referred from the HA to alleviate the burden of our public sector. This public-private sector partnership will shorten the waiting time for specialist OPC services and will ensure that the CU Medical Center will provide a wide diversity of services. The loan will be repaid or will be drawn down in 3 installments starting from 2016, and repayment will start from 2021 to be repaid repaid by 10 installments. In the first 5 years, the interest is free, and the starting of 6th year, it will be packed to our return from investment of exchange fund. With FC's approval, we plan to sign the relevant documents with CU Hong Kong in mid-2015. We'll be happy to take questions from members. Thank you, Secretary. All right, I now open the floor to members for questions. 3 members have put up their hands, Dr. Guo Ka-Ki, Pan Xiaoping, and Stephen Ho. 5 minutes each. And also Alice Mack. Dr. Guo Ka-Ki. I think we should support the government's proposal to develop private medical services. However, this time the Chinese University of Hong Kong is asked to develop a private hospital. And in itemIII, the waiting time is extremely long. Patients of PWH cannot be admitted to the medical ward even after waiting for 24 hours, and yet the administration is going to provide resources for the construction of a private hospital in itemIII. And the public will ask, what is happening? We want to provide good public healthcare services, and it's nothing new for a hospital to provide both private and public healthcare services. This has happened in the past, and professors and senior teaching staff would want to make money. They devote a lot of their time to seeing private patients. In the past, they had to do so in a private hospital. Now, they can have a private hospital. So, now, if a person without means will have to wait for 2 years if he has to conduct a surgery on his bile. And if he can't afford to wait, well, just another MTR station away, there is a private hospital, and you can have the operation done tomorrow or next week by the same doctor, but you have to pay for it. So for patients without means, they have to wait longer because the government has no resources, not enough doctors. Those who can afford it, you can do it fast track. We are not opposing the construction of a private hospital. 4 sites were earmarked for such a purpose, but 3 have now been withdrawn for public housing. I think to run a private hospital is entirely different from having a teaching hospital. We have no intention to interfere with the operation of a private hospital and whether people are making money there. But if doctors there are teaching our students, then I cannot agree. An important mission of the new hospital is to provide training. If our professors have spent so much time to see private patients and to receive payment for such medical treatment, how can they train medical students? So will they be teaching their students that if you serve wealthy patients, you can get paid at once, and if you serve poor patients, you won't get paid? Now, if the loan is provided to an organization with no vested interest, it's okay. For instance, if it is an NGO or a religious body, it's okay. But for PWH and CU Hong Kong, the same doctors will be serving in the private hospital. So it may be the case that in PWH, junior doctors are deployed to see patients, and senior and experienced doctors will be treating patients in the private hospital. The same has happened to Singapore. This is intolerable because these professors are paid over $100,000 per month. This is already happening in our teaching hospitals. This is happening in CU and also in other hospitals. So we will only aggravate the situation if we allow CU Hong Kong to operate another private hospital. How can we be answerable to poor patients who live in Shimon, Shanshui, and T-East? Do they have to wait longer because they cannot afford it? Even though there isn't enough time, I hope you can allow me time to explain why we are developing this private hospital. We've made it very clear that we have an important expansion plan for public hospitals. As we all know, in the recent couple of years, the PWH has just completed phase 1 expansion. And immediately, this is quite rare, we are now planning with the hospital on its phase 2 expansion. So I must make it very clear that we have to have development in both the public and private medical sectors in tandem. Our lecturers, professors, and doctors will be teaching here, and how can we ensure that there is no conflict of interest and the accusation that resources would be would favor the private hospital. Now, there are very clear stipulations as to the percentage of time that should be spent on teaching, treating patients, and R&D. And I'm sure the CU Hong Kong will recruit more professors. There is no ruling out that more experienced staff would be employed. So our agreement with CU Hong Kong is to ensure that public services to be provided by as PWH and teaching there would not be adversely affected. Let's see if Professor Fogg or Dr. Feng has anything to add. Thank you, Dr. Kwok, for giving me the opportunity. I'd like to take the chance to explain to you. Professors in CUHK, now they have restrictions on the time spent to see private patients. Quite similar to Hong Kong U, a professor can only see private patients in 2 sessions per week, and there is no restriction on the venue. There are very strict restrictions, and once the medical center is completed, I can guarantee that professors will not spend more time to see private patients as a result, because as said by Dr. Kwok, we cannot allow publicly paid professors to subsidize the medical center. We have very clear understanding with the UGC.
It wouldn't happen that because we have this private hospital, the professors spend more time on private cases. Rather, the doctors in the private hospitals are paid for without with a for these doctors who are paid for with private funds, they have to teach in the university. So these private doctors boost our teaching team. So it wouldn't happen that Prince of Wales would be served with less university doctors as a result of this private hospital being implemented. Now, to my understanding, now the Prince of Wales Hospital is already a teaching hospital of CUHK, and this is another hospital of CUHK with a teaching function. And you said that this will not reduce the teaching team, it will expand the teaching team. So the Prince of Wales Hospital, its future role will not be decreased, but would increase. Now, I'd like to understand. Now, a non-profit making body has to operate. Now, if you have a deficit, then how will that be dealt with? Now, the teaching arrangement, of course, would be mainly be based in your own hospital, and your document touches on the relationship with the HA. Is the HA in agreement on this arrangement? And there's over $4 billion of loan. Now, very often construction works go over budget. In such a case, will the government bear the deficit, or will it be solved by the CU itself? First, from my perspective, as I understand it, concerning the operation of this teaching hospital, the CU has considered that public-private dual track is a principle in Hong Kong, and I believe CU has confidence in this. Now, as for the arrangement between CU and this private hospital, as I mentioned, the CU has committed to receive specialist outpatient and other cases from the HA, referred to by the HA, in order to relieve pressure on the public sector, and this is something that the government is glad to see. Now, on the confidence about operation and on the development of this hospital, on the budget issue, maybe the CU can respond to that. Dr. Fong? Now, on the CU teaching element, now the Prince of Wales role is not replaceable. Now, on the number of cases, whether it's the number of cases, number of patients, the types of treatment, and the level of skill, we don't think the Prince of Wales role can be replaced. Now, the private hospital can play a role in teaching, but this is all supplementary in nature, say on communicating with patients, etc. Now, the private hospital can play a role in that. Now, on profits and loss, now, overall medical demand, demand for medical services because of population aging and population growth, there is a continuous increase in demand for medical services. And if we operate effectively, control costs effectively, deal with risks, we should be able to break even, to be balance in our budget. Now, this is a self-financing hospital. We don't expect that it will receive assistance from the financial assistance from the government. And as Dr. Koh said, our role is that it will enter into a platform with for cooperation with the HA. And the document mentioned outpatient clinic and surgical cases. Now, there will be further opportunities for public-private partnership, and we will keep discussing with HA. Now, on possible over-budget cost overruns, now this is different from government projects. We just do what can be paid for. So we plan according to the resources at our disposal. So suppose you run over budget, it won't be the government's responsibility. That's right. And on training, now the question asked is that after this private hospital is built, then there will be a new training ground in New Territories East. The Prince of Wales role will not be replaced. That's right. This is supplementary in nature. We wouldn't have more medical students just because of having this private hospital. Now, most of our students will work in public hospitals, but they will benefit from working in a private hospital. So sometimes they are too busy in the public hospital, so the private hospital will be a good platform for them to receive training. Mr. Albert Ho, there are basic policy concepts in this document that we have to sort out. The government, of course, has a policy for private hospitals, especially non-profit making hospitals. You will give them some support in terms of preferential land premium, and also you impose some controls in regard to the by means of the terms of this land lease, but will this be effective? Now, also, you are trying to assist the CUHK. You are not offering the land only. You are offering over $4 billion. It's unprecedented that you give a private hospital such a huge low-interest loan. Is that a new policy? And in future, when there are other non-profit making hospitals who request a loan, will this become a precedent for them? And if you say this is not a precedent, please finish. I haven't finished. I'm sorry. Because you might say this is CU, so I give them $4 billion. But then this is a question, this then becomes a question of subsidy to education. Now this private hospital, is it suitable to give it $4 billion by way of a teaching tool? Now, the doctors in this hospital, do they have to learn how to look after private patients? Well, you don't have to learn. You know how to take care of rich people. Any professional knows how to do that. If they can afford the payment, they will naturally get better services. You don't have to learn that. The question is, why is it not an education policy? Why is it in this panel? If you say we need such a teaching tool, shouldn't you be giving that to Hong Kong U as well? Now, I think it's not a health services policy that we should offer $4 billion. As I understand it, there are two questions. First, when we grant the land, is it only by the terms of the land grant? No. Apart from the land grant, in the loan and the land grant, we will, apart from those, we will also have a contract. The contract will list in even greater detail the obligations and commitments that the private hospital must meet. And also this is a matter of health services policy. Now, of course, this privately run hospital will be helpful to the training offered at CUHK, but we are mainly doing this from the health services perspective. The health services reform is in the direction to have a better balance between public and private sector, to a better balance in our dual track system, to make this system sustainable and to enhance it further. Now, if this is a health services policy, then this is a new policy that you offer such a large loan to an organization, even though it's an educational or say a non-profit making body to run a hospital. This is a new policy. Should the government be doing this? There are still a lot of improvements needed in our public hospitals. The government should give some room for development of private hospitals. That's worthwhile, but offering $4 billion in loan without ample discussion to this private hospital, I will not support it at this point. Now, it's our existing health services policy, a part of our reform to the health services system. Now, maybe this is the first time that the government offers a large loan to a university to build a hospital. That's true, but we've been very clear about the policy. Now, in our health services reform, be it the voluntary health insurance reform, or this one, we are trying to strike a balance in the public-private dual-track arrangement. And for over 2 decades, the government has conducted many rounds of discussion with the public to gather the public's views on how the health services reform should proceed. And we have made it clear that we will not move towards a mandatory scheme. So the government, in the end, feels that the existing dual-track system should be adhered to. Now, a very important policy perspective is that we have to keep our commitment to the public health sector so that it can further develop, so that it can be a large safety net for the entire Hong Kong public. Now, we have already submitted to the health services a panel, the blueprint for developing the public hospital sector. We have a 20 or 30-year challenge to meet the population development, to expand our public health system, to increase the hospital beds by 6,000 to 8,000. And just for this financial year, we have to invest in the infrastructure for existing and new hospitals of $80 billion just in this financial year. So this is not an independent health services policy, merely providing a loan to a university. Will that set a precedent for the development of private hospitals in future years? Now, this is not an isolated, it's an independent policy. This is a part of our dual-track policy.
Secretary, is this a teaching hospital or not? Because according to your paper, this is not a teaching hospital, but a private one. And I think this is part of your dual-track system, is that right? Yes, it is a private hospital, but since it is developed by the teaching hospital of CUHK, it will have certain teaching functions. Ms. Mack, I support this scheme. I hope that upon completion, the hospital can help to alleviate the pressure on our public sector. Private hospitals have been built in the past, however, you cannot control them. Some of them are very expensive, something we frequently criticized. So my question for the Secretary is, you have some terms already agreed to by the university. Now, there is no control over fees of private hospitals currently. I'd like to know whether this agreement will enable the administration to have some influence over the fees and charges of the future center. And Annex B or Annex C says that in the long term, the packaged fees will account for 7% of all of its services in the long term. So I'd like to know whether this is indeed the case, because I hope this can have some impact on our private medical healthcare sector, so that fees and charges will not be fluctuating. So how can you ensure that this can be implemented? And some PWH doctors are from CUHK. I know Professor Wing. Now, he sees patients in PWH, and he is also from CUHK. Now, with the operation of HK MC, I'd like to know whether you will be seeing patients in the new medical center or in PWH, because we want to lose his very experienced service. Now, this is a private sector. You may not be able to provide any teaching opportunities. When I visited Yan Hong on Hospital, I was told that trainee nurses, some patients do not prefer trainee nurses to care for them. So would this be the same? Because patients of this hospital or this medical center may indicate the same, and so trainee doctors will not have the opportunity to treat patients. In a previous audit report, where we were criticized for not ensuring that private hospitals would operate according to our previous conditions of grant. In fact, after the publication of the audit report, we have gradually rectified the situation. And the agreement between CUHK and the administration can, to a certain extent, to a large extent, help this CUHK MC. It can also have an impact on the private healthcare sector. There will be more transparency and certainty for patients. As Ms. Mack said, at first, packaged prices will account for 50% of its inpatient services in the beginning, with a view to increasing it to 70%. We have also proposed a new mechanism for regulating private hospitals. It will be backed up by legislation. It will enhance the Department of Health's power over 19 areas of operation of private hospitals, one of which is about fees and charges. There will be enhanced regulation over this matter. As regards the arrangement for professors of CU Hong Kong to serve this hospital and teaching opportunities, may I defer to the university? Thank you. Ms. Beck asked whether senior professors will be treating patients at the new medical center. Now, even in the private sector, there is a great demand for veteran or experienced doctors. However, our professors are serving in the university and not in the private sector because they are committed, and the university provides a lot of things that cannot be offered in the private sector, such as a platform for R&D and also an R&D team. Many professors serving the university are committed to teaching and research work, while we call this medical center will not be able to provide this platform. For instance, it will not have access to research grants. So, for instance, Professor Wang, I think will not certainly will not just go to serve this CU HKMC. So private doctors will give us assistance in teaching, and it's not that our experienced or senior professors will go to the hospital to teach. Teaching opportunities will patients refuse to be treated by trainee doctors because this is a private hospital. Well, in fact, this is already happening in our public hospitals. Things are very different from what it was decades ago. Without patients' consent, our trainee doctors cannot treat patients as well. It's strange that from time to time, we send our trainee trainee doctors to private hospitals, and patients there accept such an arrangement. Of course, some of them would object. Well, but again, in PWH, some patients also refuse to be treated by trainee doctors. According to Professor Tai, there is a time limit or session limit as to the time a professor can be devoted to see private patients. In fact, there is teaching opportunities in private hospitals as well as private clinics. But of course, we have to respect patients' choice. We must let patients know that we have trainee doctors or nurses around, and their consent is needed. Can you please clarify, Secretary? This hospital will employ its own doctors rather than to ask doctors from CUHK or PWH to serve there part-time. For your current professors, they can see patients in PWH as well as their private patients. In future, the hospital will have hospitals they employ themselves. So you won't be really deploying doctors from PWH to serve in this hospital. Please clarify. Assisting professors can treat private patients. There is no limit as to where they can treat private patients. However, if I get it correctly, they can spend 2 sessions to treat private patients in private hospitals, including this new hospital, and this limit would continue to apply in the future. Chairman, you are very correct. This hospital would employ its own doctors. We will not just deploy doctors from CUHK to work there. Mr. Chairman Paul, yes, we have a great demand for private hospital beds so that there can be more transparency in fees and charges, or there can be more packaged prices. Now CUHK is willing to accept certain conditions, including enhanced transparency in fees and charges, to provide a certain percentage of package prices. I think this can be a basis or standard for regulating other private hospitals, and I think it will also have an impact on other private hospitals. In theory, you would see the interest for $5 billion foregone, but in fact you can get a lot in return. It is important that we have more beds so that people who have taken our insurance can have access to private beds. Now, our proposed voluntary medical healthcare scheme is based on general ward fees. That is $650 per day. But what about the regulations under this new hospital? Professor. Of course, even in private hospitals now, how big a general ward is, well, the $650 is the basic scale for a general ward. 70% of the beds to be provided by this hospital will be general wards. So for a general ward, I mean there will at least be 4 beds. So this is important. Thank you. Dr. Helena Wong. Chairman, in future, there would be 2 systems running in parallel in CU. On the one hand, it will continue to support teaching and treatment services in PWH, and there is another new hospital. While it is self-financing and non-profit making, how do you deal with personnel matters and internship for students and fees and charges? Will, for instance, professors be allowed to choose? If you ask me, of course, I would like to work in a private hospital so that I can earn more, and I'd rather receive my internship in a private hospital so that I don't have I don't have such a heavy caseload. Because of this dual track system, I think you will face a very complicated scenario in the future. And will KMH or Hong Kong U build another medical center in the future? Because Hong Kong U is linked with QMH. I think the current system is very good.
Each university has a teaching hospital nearby. Now, very often people go to Queen Mary Hospital or to Prince of Wales hospitals because the 2 universities have professors there. But now you are running a private hospital. Now, even though you say that you will accept cases referred to by the public hospitals, yet when the cases are referred, you charge them private hospital fees, or do you still continue? You will still be charging Prince of Wales fees? Is it choice by the patient, or is it a decision by the Prince of Wales hospital that okay, you go to this private hospital, but we will continue to charge you Prince of Wales fees? Is it one hospital, two systems? Now, on practice, on practice, doctors in practice, or other medical staff in training, now it's not for them to choose. Now, say this CUHK hospital, for instance, now our medical students are also arranged to get practice in private hospitals. Now, so it's arranged by the hospital or by the school, medical school. Now, the students go to specialist clinics or private doctors' clinics to be trained. Now, as for Hong Kong U, now actually Hong Kong U has also cooperated with private institutions, including family or specialist private clinics or doctors. For instance, cooperation with the Hong Kong Sanatorium. So there's a private hospital. That also involves a cooperation between the Hong Kong U and the private organization. Of course, the financing mode is different in that case. Now, that in this case, it's a non-profit making approach. Whereas for Hong Kong U, it's a tendering process where the Hong Kong U cooperates with a private organization, and it won a bid in Wong Chuk for a plot of land in Wong Chuk Hang. Now, if it's if it's a hospital, now near Hong Kong U, why is it that it has to be a private hospital? Why can't it be in the old mode? Now actually, we do have the Prince of Wales Hospital, which is paired with the CUHK as a teaching hospital. Now, because of needs by the grassroots, we expanded Prince of Wales Hospital by phase 1, and soon after Prince of Wales phase 1 expansion has been commissioned or has started operation, we are already working on further development at different clusters. Because of different population needs, we have expansion plans for public hospitals in all these sectors. Now, we are trying to leverage on the public-private partnership. Now, some people have the financial means to choose private hospitals, and there is insufficient capacity there as well. So there is a need to expand the capacity of private hospitals too. And the last term of government now has introduced a mode whereby the consortia will compete to bid for 4 plots of land. But now we've amended the approach a bit. When we talk about the healthcare industry, we should have a long-term target because for both the public-private sector, we do not have the capacity to meet the needs of the public. So let's drop the goal of developing our health services industry internationally, and we will try to take care of the public's needs. So we have stopped the bidding for the remaining 3 plots of land. Now we are encouraging non-private bodies to, non-profit making bodies to run private hospitals in a non-profit making mode because of this shortage in capacity. And so this is part of our policy. So that's why we have this non-profit making hospital for CUHK. Mr. Yu Si Wing? We are short of hospital beds in Hong Kong. That's a fact. And we need to increase the number of beds. So the government is providing a loan, and the rest of the funding is by the university. So I think this is worth our support. Now I have a question similar to that of Ms. Mack. Now the teaching hospitals are now the Queen Mary and the Prince of Wales. Now they have a long history. They have plenty of experience. So the training arrangements for the public hospitals serve a function that the public is amenable to. But on this private hospital, people may wonder why is it that the public funds are used for this kind of training, and you call this the CUHK. Now, the name gives people the impression that this is a university hospital. How do you, no matter how you explain, people get the impression, including me, that this is a university hospital. So you just call it a hospital and not say, don't tell people that this is a training institution, because this may lead to a lot of misunderstanding or even rumor. People may think that, oh, we are being treated by students. Now, so let the training be done at the 2 existing training hospitals, at least initially. Only after the conditions are right should you embark upon training arrangements. Otherwise, people may lose lose confidence in this hospital. I thank Mr. Yu for being proactive in reminding us about the impression that people may receive, especially the patients. Now, the leadership in CUHK should do well to consider Mr. Yu's point, but I also hope that Mr. Yu can understand for medical treatment, right from the beginning, is intertwined with health service. So training and service are intertwined. Now it's a relationship between teacher and pupil. Now we are more systematic, but still to a large extent it's a pupil following a teacher and learning by observation. So it's always a fact that when there's health service, there's also a training element. So the public should understand that the person under training will not actually be the one who provides the cure. Now, for those interns, that's a different case. They are learning, and also they are also offering treatment. So the students would not actually be engaged in the training, in the treatment. there will be a transparency for the patients to know who are the students, and the patients will have the right to choose whether to accept that. Now, not all patients are scared of being treated by or handled by students in training. Now, not many people would think that there are students in private clinics. This is happening. Many well-qualified doctors, private doctors, help to train students. Now, on the name of the hospital, please go back and consider. Mr. Albert Chen. Now, conceptually, for the medical school of the university to develop a hospital, well, that seems well-grounded. Now, academic institutions usually give people confidence if they are going to run a hospital. And people respect teaching institutions. But in the past, there have been problems. A certain HKU doctor deceived the university regarding surgery fees, and the Hong Kong U had a lot of problems with its investment in Shenzhen. We don't know how it would end. So when it comes to financial matters, people say the devil is in the details. So it's a grand concept, and people think this is good. But when it comes to implementation, you might achieve certain objectives, or you might achieve certain standards of service. I won't deny that. But maybe as a result of this development, some people will gain certain privileges and be able to profit from it. Well, when it comes to fans of C.Y. Leung, well, I wouldn't count the names except Paul Chen. Now, the IT Bureau, that's another case. The research fund is $5 billion, just that fund alone. So we are worried how you're going to regulate the possible transmission of interest. Now, there might be three queues, public, private, and this third queue. And some people might be able to choose from the three queues to choose the fastest queue, whereas another would wait forever in a particular queue. So I am concerned. I don't want to stand in the way of a good proposal. I don't want to oppose you in every case. I want to encourage you, but you need to convince us that there won't be anyone gaining privileges in the queuing or in making of profit, and also in accountability. Can you reassure us?
Secretary. Well, when there is private and public sector running in parallel, and if doctors are allowed to serve in both sectors, how can we prevent the scenario mentioned by Mr. Albert Ho? Let me explain to you that it is in fact the other way around. In other countries, if a doctor is allowed to see both, I'm talking about patients queuing up for services. Yes, that's exactly what I mean. Please listen to me. In other places, patients will have to pay if he consult a doctor in the private sector, but not in the public sector. and a private sector, the private doctor may allow him to join a queue in the public sector, and that will be unfair to patients in the public sector. In Hong Kong, for some selective operations, it's true that patients have to wait, but even without a new hospital, if a patient who is waiting for operation has got insurance coverage or for whatever reasons, can choose to leave the public queue and consult a doctor in the private sector and have the operation done in a private hospital. Of course, he has to bear the medical costs. And we believe this is something good, because once this patient has left the public sector, then other people in the queue, they are grassroots, will see a shorter waiting time, because someone has left the queue to look for private services. So it is important that the doctor cannot arrange for his private patient to join the queue, to jump a queue in the public sector. What about abuse of power and transparency? Historically, it's true that we have such cases of abuse, and in the public sector we have done a very thorough review, and we've done a lot internally to prevent this from happening again. So when a new private hospital is established, I'm even more confident, because it is a brand new hospital. Whereas in the past, we are talking about teaching hospitals with cooperation between a public hospital and the medical school. Many practices has got a long tradition, and it's hard to remove them at once. But I'm quite confident that this new hospital will have a proper audit system in place right from the beginning to prevent such cases from happening. I don't know whether the Pro-Vice Chancellor has anything to add. Thank you. I'd like to take this opportunity to say that we have thought of many ways to prevent abuse of power and transfer of interest, and also two systems in one hospital. This is to address Ms. Dr. Helena Wong's question. You may think that the university will run this hospital. This is not really the case. The university has set up a company to run the hospital. The medical school will not run this hospital, because we do not have any talents to operate, or expertise to operate a hospital. So there is only one representative from the medical school in this new hospital. All others are either independents. So we will have a very strong governing structure. We will be as transparent as possible. We will ensure that there is no abuse of power and transfer of benefits, and will ensure the professors will not be spending unduly long time to treat private patients. Chairman, did you ask us to declare interest? There is nothing to declare unless you are in CUHK. I don't see any need for declaration of interest. I'm an honorary assistant professor of CUHK. Oh, okay. It seems that this hospital has no pediatrics. What is the reason for this, given that there is a great demand for pediatricians or pediatric services in the community? And this packaged prices is just a concept. In private in existing private hospitals, I don't think this has been thoroughly tried out. And we don't know whether the concept of packaged prices will work or not. Now, if this is included in the grant, and if it is found to be infeasible, how are you going to address the problem? If with packaged charges or prices, the hospital will be in the red, then will you modify the grant? Or if this is not taken up by the market at all, meaning that only 20% of the patients would take up packaged prices, and if you fix the percentage, that means the hospital can only operate up to 40% of its capacity. Now, because you have not tried this out before, it may be infeasible, and what if it turns out to be the case? The third question is a bit more complicated. You say in the paper that the hospital would accept cases referred by the itemIII, and the patients will be charged at the standard rates of the itemIII. That means itemIII and patients do not have to pay extra. That means these will be these cases would incur losses for the hospital. So for every case treated by this hospital, it will incur a loss. Why is the hospital willing to do so? Because it has accepted a loan from the government, and it treats this as a loan, as interest. Perhaps CU doesn't know about the operation of private hospitals, because even for standard patients, existing private hospitals would fulfill the request, because any extra request will incur a charge. For instance, for a certain examination, I have to wait for a week, and I would rather have it done at once today, so long as I'm willing to pay extra. This is what's happening in private hospitals now. So if you accept referrals from the itemIII, would you entertain such a special request for services? And how can you ensure that these cases are receiving services on a par with their counterpart in the same hospital paying private fees? Yes, for packaged prices, indeed, in our service agreement, it will be specified. Is it true that we don't have packaged prices in Hong Kong? Of course, that's not the case. Some hospitals, some private hospitals already offer packaged prices. Some overseas hospitals are doing the same. So I'm quite confident, because the hospital will employ experienced administrators, and they will make reference to practices in other private hospitals. So I'm quite confident that packaged prices can work. As regards special requests entertained by patients. Now, if a patient is admitted to this hospital at package prices, and if he is asking for something extra, of course he has to pay for it. And even as a doctor, I cannot say that as a private doctor I will entertain every request of a patient. I'm talking about the hospital. Well, even in a hospital, it's dependent on the decision of the medical officer in charge. If I am the doctor in charge, I'm of the view that certain examination or procedure requested by the patient is not necessary, I won't entertain his request. And if it is something I agree to, and if it has nothing to do with the package that he packaged the price, then I would of course charge him extra. This is my view. I don't know whether CU shares my view. Well, we do have pediatrics here. What have I missed it? Well, all specialties offered by CU will be offered in this hospital. We have only highlighted 4 specialties because they are the core services required by the government. So you do have pediatrics there, yes. What about packaged prices? Yes, there is experience overseas, and we believe it will work in Hong Kong, although it's not tried out here yet. And we also have to work with the insurance sector. At present, there aren't too many packaged charges available because of the ease of risk, but we are confident that we can do it. As for a special request, I think the Secretary has provided a very detailed reply. In private hospitals now, some operations or examination don't have to be done after normal office hour. It can be done. Wait for the next day, but some patients request to have it done at once. Now, private hospitals are commercial entities. Any request that is reasonable and acceptable can be done. And according to the Secretary, it is an extra request from the patient, and if he's willing to pay for that, it can be done. That means the package offered at a fixed price has got restrictions. It will not underwrite everything, right? Are you talking about choosing the date, a particular delivery date? So a patient wants a certain procedure to be done earlier. So it is something outside the package. So extra fees will be charged. Is that right? This is what I understand. Yes, something that is outside the package will have to be charged extra. Now, if I am admitted today of removal of the bile, and there's some examination beforehand, and also the operation, and a certain length of stay after the operation, that's within the package. If a patient wants an examination of the mammalian gland, then it is something different. You talk about any procedure that has to be done at a particular time. Now, if it is acute inflammation of the bile, is diagnosed in the evening, it can be done late in the evening or the following morning. Both can do. Oh, you're talking about the time when an operation should be done. So, because the price is different.
First, depending on the time. Now, there is for the doctor, for the hospital, when it decides the package, to decide whether the service is provided 24 hours a day. So it's a matter of the design of the package. Before such packages are designed, even the CU representatives here will not be able to give you the detailed answer. Now, but you may be pointing out that the hospital will have to pay heed to these issues when it designs the package in the future. I think they will thank you for that. The other part of the question you haven't answered is that for those cases referred by HA, you will charge the stipulated fees, but and they might lose money. Now, our agreement with the hospital will state the quantity of case referrals. So we do not expect the hospital to charge additional fees beyond that. Dr. Fernando Cheung. Now, Hong Kong is short of hospitals now. Now, the CUHK Medical School wants to develop a hospital. The concept is worth supporting. Now, we are using public resources. The premium is nominal. The loan is $4 billion, subsidized interest rate, and CUHK has a good reputation along with the Prince of Wales Hospital. It has offered training, and some of the training will be moved to this private hospital, and it's going to be a middle-class hospital for the middle class. 70% of the charges will be on package basis. So 70% of the services. So in using public resources to support a private hospital, I'm concerned that there will be less resources for the grassroots. Or shall I put it this way? If the same amount of resources are to be placed in the public hospitals, will offer greater help to the grassroots. Now, I'm not saying that we shouldn't assist the middle class, because I would also classify myself as middle class. But still, public resources should mainly go to assisting the grassroots. The middle class have their own resources. They can decide. Now, this is a loan. Well, interest-free loan, that still involves public resources. The land premium, $1,000, that's public resources. Now, also, now if some of the teaching staff, like CUHK professors, are serving at the private hospitals, then the middle class can have package services, and they will be attended to by reputable professors, whereas the grassroots patients will not have that opportunity. Now, in Queen Mary or Prince of Wales, there may be senior professors doing research or treatment there, which will benefit the broad public. Will that arrangement be changed in the new hospital? On the second question, now actually the Pro-Vice Chancellor made clear just now, in developing the new hospital, the CU will engage a new team for the new hospital. It will not affect the personnel at the Prince of Wales Hospital. So the broad public will still be able to enjoy the service of senior professors of CUHK. Now, on public resources, as an accountable official, I often ask myself, in this process, the grassroots members of the public who need the help of public resources, will they lose or gain in this arrangement? Now, firstly, the government has decided on a public-private dual-track system. We spend public resources to facilitate public-private partnership. Some of the resources are spent on the future voluntary health insurance. Other part of the funds for the building of public hospitals, and other resources will not be directly invested in the public sector, and that's evident in the current budget, whether it's in the blueprint for development of public hospitals or for the 2,000 odd beds mentioned in the budget that costs $80 billion for the development of the public sector. Now we then spend a little more public resources in for the development of private hospitals. Now the patient will be able to move to a private hospital that has received assistance of public resources. Now, for the patients remaining at Prince of Wales Hospital, they don't have to wait so long because some patients will have moved to the private hospital, and the patient at the private hospital also has to pay out of pocket, either through cash, or either by cash or through his health insurance scheme. So overall, there are more resources invested in the health sector. The government pays a little resources, and as an inducement for some members of the public sector to choose to patronize private hospitals, and as a result, the amount of health service resources available will be increased. So it's a leverage principle. The government spends some money, there are more resources provided in the private sector, and so the pressure on the public sector is reduced. Now we have exceeded the time limit for this item of agenda. Kwok Ka-ki and Leung Ka-lau. Now, on the Secretary's points, I will not oppose that to the policy of expanding private hospital services, but this is being left to a university. I am concerned that it affects the time available to the professors. Now, for the professors, they are limited to 2 sessions in service to private patients, but it's difficult to monitor. And what is the amount in relation to the salary? And also, this is an unprecedented approach now, and there will be issues arising. Now, before this goes to the Finance Committee, I think the government should try to answer our questions. Thirdly, in the past, when land is offered to NGOs or charitable organizations to build hospitals, there would be charitable or free of charge beds, or that beds that are free of charge. Now, according to the documents in St. Teresa Hospital, in theory at least, they are providing 100 of these beds. but according to the media, they find ways so that the patients won't be able to make use of them. So I don't know whether the poor patients can benefit. Now, also, the CHK says that it will not affect the teaching, I hope you can give us more numbers. You say that the staff now, how much time will they lose as a result of attending to cases in the private sector? And for the more senior doctors, they are more inclined to handle the private patients because some of the service fees go to the professor, the rest goes to the university. So it's a zero-sum game. The teaching staff, they spend the time on private cases, so they will spend less time on teaching and research, and they also have to spend time in meetings. So this is confusing. And CUHK, you can build a private hospital, but the problem is that the teaching staff is mixed up with this private hospital. Now, there are cases at CUHK and Hong Kong U medical schools where the professors spend some time, I won't say a lot of time, on this. Now, we are told that it's very difficult to get these professors to treat you unless you pay. You are not a research subject, then you have to pay. And if you are not rich, then it would be the junior doctors who would be attending to you in your specific queue. Now, you are setting a precedent. This is unusual. It's abnormal, and you make this proper, but when you inject funds this way. Now, Leung Ka Lau, now I think the Secretary may not be able to answer me right now, but I hope you will be able to provide a detailed answer before you go to the FC. That is about the referral arrangement, because this arrangement is unprecedented. You say you refer new cases to a hospital. Now, this is different from the public-private partnership that we have had to date. You have to tell us in detail how you do it, because when you refer these cases, you have to have clear service indicators so that it's not abused. But looking at this referral arrangement that you talk about, it said that an intestinal case is a new case. Now, so the HA hasn't found out about what the nature of the case. Maybe blood found in feces. It's not resolved after 2 years, so we will refer this to to the new hospital. The Prince of Wales hasn't looked into it. So, do they need to re-examine him because there has to be enteroscope examination? because in that case the cost would be over $10,000, and you refer a new case, you don't know what is involved because you are proposing a new model.
Now, if this model works, you don't have to wait until the new hospital is commissioned. You can immediately refer cases to private service providers at the cost of the public sector. So please explain to us the government's concept in greater details later, how you can deal with new cases. Regarding the first and fourth questions by Dr. Kwok, I will defer to CUHK for the second question. I thank him. And for the third question, I think it is somehow related to Dr. Leung's question. Dr. Kwok. Let's talk about free hospitals, free beds in private hospitals. In fact, we're not asking for a certain percentage of beds to be reserved for us. Rather, we have fixed a certain quota for patients to be referred to the hospital. Of course, the type of cases will be decided later. Anyway, the hospital will have to accept these cases. The patients will be paying as if he were in a public hospital, and the hospital will not charge the HA so long it is within the quota agreed to in the service agreement. And I think Dr. Leung is asking a similar thing. He would like to know the content or details. Will it be something entirely new? No, I don't think it would be an entirely new case, just a case of tummy pain, for instance. If we do this, we may not be able to maximize the benefits. There may be blood in the excreta of a patient, and there may be stomach pain, and he may improve after some rest. So once a patient is referred, it must be the case that a certain operation is already confirmed, so that we can more easily quantify the number of cases. All right, please give us information before you go to the FC, so you can have better performance pledges and indicators. Dr. Kwok and Dr. Leung ask for some statistics. I think you should supply them later. And for cases referred to this new hospital by the HA, you will not charge him extra. So according to Dr. Leung, that will be like interest you pay to return to the government for the loan. But for the current model, you can't do that, because currently private hospitals have not taken any loan from the administration. Well, please give us a paper to confirm. I agree that there can be more communication so that we understand each better. Yes, it's because we've provided a loan to the hospital for its development. It must in return give us benefits to the community. So you are using interest due to you to subsidize the treatment of HA patients, right? If my understanding is correct, can you please give us information before the FC meeting? Yes, conceptually speaking, this is to offset revenue forgone by the government in the form of interest for that loan. All right, we have overrun, and this paper will be submitted to the FC. So I'd like to know whether members support or oppose this paper. If there is no objection, thank you very much. before this paper goes to FC, please give us supplementary information. All right, we go on to the next item. Members may recall that the Secretariat has done this report for us. It was submitted to the administration, and today we would like to listen to the administration's response. We will have some public hearings on regulation of private healthcare services. So, members, the administration is here to discuss administration response to research study on regulation of aesthetic practices in selected places. I'm sorry, we're a bit late, so you don't have to brief us on the report. Yes, just a very short response. Yes, the Secretariat, the Logical Secretariat has done research on regulation of aesthetic practices in selected places. In October 2012, the administration also set up a steering committee on review of regulation of private healthcare facilities with 4 working groups, one of which is the working group on differentiation between medical procedures and beauty services to deal with high-risk procedures of cosmetic services because some procedures have inherent risks and they can only be done by registered medical doctors. And these procedures include injections, medical chemical exfoliation of the skin below the epidermis, hyperbaric oxygen therapy, and dental bleaching, and so forth. And the recommendations were endorsed by the steering committee in November 2013. For medical devices, for those that can emit high energy, such as intense pulse light equipment and medical lasers and so forth. We need to conduct a more detailed study, and we will consider commissioning a consultancy to study this issue, and then we will consult the beauty sector afterwards. This report has helped us to understand the different modes of regulation in other jurisdictions. Thank you. I think we have had a number of discussions already, and we are grateful to our research division for doing this study for us. So we have got a paper in response from the administration. Dr. Helena Wong. Each member may speak for up to 4 minutes. First of all, we must thank the research division for doing this study for us. I hope that the chairman can arrange a public hearing with other relevant panels, because we need someone from the some areas have to be followed up on by the health services panel, but other areas may involve advertisements, training of beauticians and their examination mechanism, and there is also the regulation of the beauty care sector and how to enhance the quality of the beauty care industry. This may involve the Commerce and Economic Development Bureau. So, Chairman, I hope you can arrange a public hearing and invite other panels and bureaus from the administration to be present. We can also invite the Consumer Council. In response to some of the comments in the report, I think it was last year or last session, we passed a motion in the Council on regulation of the beauty care sector so that there can be improved quality and safety. I'd like to know whether the Secretary has done anything subsequent to the passage of the motion. Under Secretary. As we've always explained, our primary concern is safety and marketing practice. When it comes to safety, our steering committee has got a working group on differentiation between medical procedures and beauty services. And a differentiation is made on the basis of risks involved. Some aesthetic procedures may be high risk, some may be not. For ordinary procedures, they already are regulated under the current legislation, so we have no intention to regulate them. We are more concerned about safety, so for high-risk procedures, such as the regulation of private healthcare facilities, this is our primary concern. And there is also the specification of competency standards for the beauty sector. They have got the qualifications framework. The sector have got their own QF. Please, no dialogue between the two sides. Allow the Undersecretary to finish first. We believe that existing channels are sufficient, so our focus is mainly on the regulation of high-risk procedures. What about examination? In the UK, they have government recognized bodies to award certificates for the use of lasers. Now, for IPL, there is a test, but for medical lasers, I don't think there is any examination. And the beauty sector would want you to have a certification mechanism so that they can use medical lasers in aesthetic procedures. Yes, I think the beauty care sector is very concerned about this, and we have done a lot to differentiate different medical devices into different levels of risk. And also we've also done an regulation impact assessment, but views are diverse in the sector, so we'll set aside this for the time being. We'll first look at regulation of private healthcare facilities first. For cosmetic-related medical services, devices, we will consult a consultancy before we decide on the next step forward when it comes to the regulatory framework. Mr. Pan?
On paragraphs 9 and 10, the qualifications framework is already implemented. Now, how many of the practitioners have joined the QF, and what's the percentage? And how does the government encourage people to join? And looking at paragraph 19, it says that the Department of Health has come. There are 4 cases of being prosecuted and that have breached the rules for the beauty centers, and the penalties have been quite low. How do you intend to raise? Do you intend to raise the fees? And Para 20 has found 11 cases of practice that are in breach of the requirements. Now, is it a result of inspections by the DH? Now, on QF, now we don't have the data because mainly it's the Education Bureau that's responsible. Secondly, on the penalties, now is it sufficient? Is it too light? Too light? Now, in our current review by our consultant, they will look at that, and so based on existing legislation, we will follow these existing penalty levels. Now, on the third question, inspections. Concerning practice without license, how did we uncover it? Now, it's from different channels. First, we look at the advertisements by the beauty centers, whether they advertise procedures that require attendance by a doctor. Secondly, we learn through complaints and cooperation from the Consumer Council and other information that we receive. And when we find that there are grounds for suspicion, we will refer the cases to the police for follow-up. And in the procedure, we also offer full support and assistance to the police. So out of the 11 cases, how many of them are from complaints and how many are from inspections? We don't have the information. Now, on the QF issue, can you provide the data later? Because the Education Bureau is doing the work. Is it already done? So please let us have the information. Dr. Kwokaki. Now, on the study itself, it's been pointed out that there needs to be supervision on the beauty industry. However, the government offers us no timetable on such supervision, and there's no blueprint. And in the consultation just concluded on the regulation of private healthcare facilities, now some of it touches upon the contents of this document on clinical treatment. Now, so this study is rather belated. Now, very often the services are not done by the doctors or healthcare workers, but are done by persons engaged in illegal healthcare practice. They do not have sufficient training, or they give high energy treatment where there is no need. So there needs to be supervision of the industry as a whole. Now, even though you have QF, do they have to follow the rules? If you don't catch them, catch the cases of practicing without license, then they can keep on doing it. And the inspections by the DH are far and few in between, and there have been cases reported of injections without license. Now, it's not just the DH or the Food and Health Bureau. The Commerce and Economic Bureau also has to be involved to regulate the industry, the licensing system. There should be a points system to etc. So we've been talking about this for over 10 years. Is there a clear timetable by the government? The Undersecretary, you may not be able to do it in your bureau just by yourself. Will you cooperate with the CEDB? What's their response? Will there be a licensing system, a point system, a demerit point system? Now, as I said, we at our bureau we are most concerned about the safety issue. So the work that we've done is to differentiate the medical from the beauty procedures, and we pay attention to the risk. Now, in this regard, now apart from the practitioners, the premises need to be supervised as well. That's what we are looking at too. Now, I don't have much time. Please answer my question. Now, the efforts by yourselves and other bureaus on the licensing system, etc. Now, you have not answered me. Is there a timetable? Now, the consultation yet to be done on the premises. Now, the next stage of the work. Now, well, we are all concerned about the treatment devices. That's also an important concern of ours. So our legislation will be in that direction. We agree with what you said, including the devices, practice without license, and so on. But you haven't answered my question. The industry is engaging in a lot of things that it shouldn't, charging fees indiscriminately, getting customers indiscriminately. Did Mr. Gregory So work with you? We do not intend to regulate the beauty industry generally. Now, in the past 5 or 6 years, we have been discussing this, and there may also have been public hearings, different departments, the FHB, Education Bureau, the CEDB. There have been cross-bureau public hearing. Now, I won't dare to say that there's no regulation. Concerning beauty, there's equipment, then there's personnel, and then the premises. How do you regulate that? Now, that's quite apart from practicing without license. Now, she wouldn't be able to give you an answer on the timetable. Maybe that we can talk about that at the public hearing. Can we broaden the public hearing? Through the Secretariat, we'll invite the 3 bureaus and the relevant deputations. So the report makes clear that there is no specific legislation to regulate the industry. So we will deal with that. Ms. May-Kun, now, I don't agree with Mr. Kwok-Ka-Ki that the beauty industry is in chaos. Now, the previous fatal incident was done there. A doctor was involved. So the last fatal injection incident, that was by a doctor. Now, the extraction of fat, that was also done by a doctor. It shouldn't have been done. It was done in a clinic. Now, we have been in touch with the Undersecretary on a number of occasions. Now, the beauty industry doesn't mind engaging in training to make themselves more professional, but colleagues mentioned this. They have a qualifications framework. They set for the courses. They took the courses and they felt they have become more professional. And now the government says that certain devices are not to be used, certain practices cannot be engaged in, so you will study that. Now you have no specific license for these beauty centers. It's another bureau that looks after that. Now you say you want to regulate that, so why don't you just set the rules and have somebody to assign to regulate them? Now it's the doctors who engaged in these fatal incidents, but they exploited these beauty centers and carried out these fatal incidents in those centers. Now, the government should try to eliminate such occurrences by through proper monitoring of the medical registration system. The government should also try to regulate as quickly as possible these beauty devices. Now, otherwise they will have a bad name which is not entirely deserved. Now, you should fully consult the industry. We don't want the consumers to suffer in health, etc. We hope that the regulatory work can be done well, but we hope that you conduct proper consultation. Otherwise, you introduce some measures and people object, and then you take back the measures. The Undersecretary, now on the regulation of medical devices, now we are trying to identify the consultant. We hope that by the end of the year, the consultant will have completed the report, and that's our rough timetable. And when the study has been concluded, i.e. Study on practices in other countries, we will consult the beauty industry as well. Now, I hope that you will also discuss with other departments such as customs and excise. For instance, the Trade Descriptions Ordinance already covers can be used to cover the beauty service. The Department of Health can step up the inspections. So in your legislation, before your legislation, before your new regulation of medical devices, maybe you should step up the implementation of existing legislation. Now, Helena Wong, 3 minutes. Now, the Undersecretary says they don't want to regulate the beauty industry. Actually, the beauty industry practitioners tell me they want such regulation. They want the level of the industry to be raised. I hope you would work with other departments. Now, on the laser and other treatment, now for itemIII there is no professional accreditation. Now in 2013 the government got Lobingham to engage in a study, and that was a 2013 studies. There were 5,000 firms, 2,200 of them have the laser and itemIII equipment. Now, are these firms safe? The beauty industry want the practitioners to sit for the level 3 and level 4 laser exams. Can you work with the Education Bureau so that they can be recipients of certificates after they complete the training, and they want to take the exams, but there's nowhere they can take the exam. We want the FHB to talk with the EDB so that they have these laser exams so that people can get some assurance that they are offering safe service.
Perhaps I can defer to the Assistant Director later. It's not that we do not have any regulation at all. Different levels of lasers are being used at different places. Perhaps the Assistant Director can supplement. Dr. Choi. Yes, the use of medical lasers. Dr. Helen Wang said that some cosmetic centers use medical lasers. In fact, there are different levels of power and different that with different level of invasion and risk to human eyes. The risk will be different depending on the power of the medical lasers used. So it is not as simple as just asking the beautician to take an examination. Our consultancy will look at this very carefully to see whether there is any type of medical lasers that can only be applied by medical staff, and the type that can be applied by people with some training, and also the situation in other places. We hope that the consultancy can give us more information in this area before we consider the regulation of the use of high-power medical lasers. All right, when will the consultancy be done? Our target is to have it completed by the end of this year, and then we'll come back to report to the council. I hope you can speed up because such devices are already in use. If you do not expedite, then if there are incidents in the interim, I don't know who should be held accountable, you or the undersecretary. Yes, we do understand that. We hope that the consultancy can be done as soon as possible, and then we can come back to discuss with proposed legislation of cosmetic-related medical devices. All right. So there will be a public hearing involving joint panels, and we hope that you can come back to us with the consultancy report by the end of this year. May I remind you that we will end at 7 p.m. today because we have 3 things on our agenda. Okay, the next item is progress of General Outpatient Clinic Public-Private Partnership Program. We've got a paper on that. Perhaps the Undersecretary can give us a very brief introduction, and then we can start the questions. Thank you. Thank you, Chairman. This paper reports to members the progress of the General Outpatient Clinic Public-Private Sector Partnership Program launched by the HA in Kwun Tong, Wong Tai Sin, and Tuen Mun districts. Members may recall that at the meeting dated the 17th of February 2014, briefed members on the details of the partnership program, and we undertook to report to the panel the progress of the program 1 year after implementation. Since the introduction of the program, we've got a very positive response from private practitioners as well as patients. Dr. Zhang from the HA will supplement later. Because of the aging population, we'd like to further public-private partnership so as to meet the demand of society. And then in 2015, the CA announced its policy address that the partnership program will be extended to the remaining 15 districts. And in 2015-16, the FS has reserved in its budget or has undertaken taken to provide $6 billion to the HA for implementation of the scheme. And the HA is now working out a program framework. We will submit a funding application to the FC within this year, and we hope to come back to this panel in the fourth quarter for details of the funding application. Dr. Zhang, because time is limited, I think I will reserve more time for the discussion, so I will just mention one point. The program is still in progress because we are going to invite patients in batches. The program has been in place for 8 months, and 3,600 patients have joined in, and 3,000 of them have started receiving medical care from the participating private doctors. We expect that another 600 patients will join, or rather, we hope that ultimately there will be 6,000 patients under the program. We are quite optimistic that we can achieve these targets, and then we will consider how the program can be extended to other districts. Any questions from members? Ms. Alice Mack? Chairman, the paper mentioned that the number of patients that have joined the program. Have you got any figure on the dropout rate? And do you just consider the number of patients and private doctors joining, or will you give appraisal form for patients to fill out to see whether the program is helpful or not? And has any patient ever complained to you that they're not able to get the prescription or the medication they want from the private doctor he consults? Any dropouts? Well, we have been watching the situation in early March 2015. We've got about 1% or more, or rather 42 patients who have decided to return to HA for follow-up after joining the program. For some of the patients, it's because their clinical conditions require them to receive treatment from HA, and some also passed away. Regarding the review, we will consider the procedures for patients to see the private doctors and the use of itemIII, and we also asked patients whether they are satisfied with the program or not. Regarding medication, perhaps Dr. Zhang can supplement. Medication covered include 29 drugs for chronic diseases such as hypertension and diabetes, and also 3 types of drugs that can be provided by private doctors. All these are covered under the program. If the medication sought by the patient is beyond the scope, then the patient can negotiate with the private doctor. When we conduct a review in the middle of this year, we will see whether we can increase the number of drugs for chronic diseases and for episodic diseases. We will have recommendations in the review to improve the program. I hope when you come back to us to tell us the findings of your review, please tell us how patients rate the program to see how useful it is to them. Dr. Leung, have you got statistics as to the number of patients that have returned to OPC of HA after joining the program? And do you have indicators to gauge the effectiveness of treatment other than asking patients? For instance, do you have indicators to find out whether blood tests have been conducted for diabetes patients, to look at the blood sugar level and did you have any objective indicators to gauge the effectiveness or the level of care provided by private doctors? And what do you think will be the patient population suitable for joining the program? I know you have about 6,000 in mind for this pilot scheme, but do you have any idea as to the patient population in the whole territory? Thank you. We've just started this program. Of course, Dr. Zhang can tell you more about the figures, but since we've just started the program, Dr. Leung's question as to the effectiveness of treatment, we may not have any statistics at this moment, but in each district we have a particular unit to look at a number of things, including the effectiveness of treatment. Dr. Zhang can supplement, and the number of patients that have returned to HA. Dr. Zhang, please supplement. Yes, patients might not have opted out of the program, but have they returned to our OPC for treatment? We are aware of their names, so we are going to compile this statistics, but we're going to do this in the review. So far, we haven't got the statistics yet, and we'll have a few indicators to ensure the quality of treatment. First, the private doctor is required to enter clinical records into the EPR system in things such as the blood pressure, and blood tests are required on regular basis to test for hemoglobin 1Ag, for instance. All these tests are done by government laboratories, so we do have such records. And the ultimate patient population we can serve, I think this is an evolving process. Right now, we only target at patients with hypertension and diabetes. If the program is extended to all 18 districts, and if it is well received by the community, the types of patient of diseases can be expanded to cover more than hypertension and DM. And we're also choosing patients with simpler medication in phase 1. So we do not cover patients that require to take 6 to 8 types of drugs for the time being. But can we relax the threshold at a later stage? Yes, that can be considered. As regards patients being treated by the HA for hypertension, we have hundreds of thousands of patients. But are we going to include all in one go? I don't think so. We will discuss with stakeholders gradually, but we will mainly focus on chronic diseases, and we are going to cover more such diseases in the future. Or you allow 4 visits for hypertension or DM and 6 visits for episodic diseases. Now, if a patient has got constipation and he needs to take medication for that in the long term, will he have to withdraw from this program and be treated by government OPC or SOPC, GOPC or SOPC? For a simple disease like this, can it be covered by the program? Because you've only selected patients that require medication on hypertension and DM only.
Two sorts of situations. The first, episodic. Constipation might be episodic. The 3 days of medication should cover that. But if the constipation is regularly occurring, then that depends on whether it's covered among the 29 medicines in our system. Right now, there is no medicine in there for constipation. Now, if he wants to get the service, he can discuss with the private doctor. He can pay out of his own pocket. But as I said, we will review the coverage of our medicines for this system. If we need to, we can increase the number. Can you give me a table or list of those 29 medicines for reference? Is it on the website? Please let us have that for a record. What are those medicines so that other members know what are those simple type medicines, what they are for? Now, because there are cases like constipation, now the medicine is very low risk. Now there are many HA patients who only get medicines for constipation. Yes, let us have some information on the nature and uses of the medicine, because some of us are not professionals. Helena Wong, now I'd like to know what are the resources, because you are now only providing service at 3 districts, Wong Tai Sin, Kwun Tong, and Tuen Mun. Will you consider the other 15 districts? Now, in paragraph 15, you say that in your future considerations, you will look at median income, etc. for that district. Now, if you want to provide service for the grassroots, please quickly consider Kowloon City, Sham Shui Po, Yau Ma Tei, Mong Kok. There are many residents in the partition units, etc. there. Now, I hope you can step up the pace of your review, because I believe there are many in these districts who want to join the scheme. Who will respond? Now, actually, well, I think, Ms. Wong, why these 3 districts? Now, you mentioned median household income. That's only one factor. We will also look at the demand in the districts and whether the number is high in the HA cluster. If there are a large number of such cases, the queue is long. So we hope that these patients can go to the scheme so that the other patients don't have to wait so long. So these are factors that we will consider. Of course, we will look also at the other districts. Our next step is to look at the other 15 districts on the basis of these factors to determine the priority. Dr. Chiang, anything to add? Now, on those 3 districts, as the Undersecretary said, the demand is stronger there. Now, median household is low, household income is low, so they rely on subsidized medical services. Secondly, elderly people. Now, there are more elderly patients at GOPCs, so these are the factors on which the 3 districts were selected. Now, when we embarked upon the GOPC, now there are other schemes in operation, so those districts were not chosen because there were these other schemes. But now those other schemes have ended already, so we can select some of these 15 districts. Also, we will consult the district councils on their views as to whether they decide a higher priority. and the number of private doctors who are likely to join in each district is also a factor that we will consider. Please give priority to Kowloon City and Yau Chim Mong. Now you choose districts where there are more elderly people and where income is low. Now for the 3 districts chosen, now has the queue at the GOP C's been shortened. Now in these districts, it's difficult to get an appointment. So we have launched the scheme only for a short time only. So it's not early days yet to decide to determine the impact on the GOPCs. Now, if there are 3,000 patients, 10 consultations a year, then it's 30,000 consultations a year. Now, so 30,000 consultations taken from our GOPC, we can then work out what's the percentage. Now, I remember that under this scheme, the medicine has to be from the UK, from the HA. Now, this doesn't have to be the case now. We allow the private doctors to get the medicines from our suppliers at our prices, so it's a lot cheaper. They can use these medicines for their patients. So this makes it more simple to deal with the medicines. It avoids audit problems. The patient can get the medicine at the private doctor's clinic. So the private doctor can use these medicines only on these patients. The doctors can use these patients on all his can use these medicines on all his patients, but we do have a limit. We set a limit for the amount of medicine that he can get each time based on the number of patients who have joined the scheme at his clinic. So we have completed our agenda. We hope that you can come back when the report is completed to provide us more updated information. There are no AOBs, so next meeting in April. Thank you. There are 3 bureaus involved, so the secretary will arrange for the meeting.